Hey there, thanks for tuning in. My name is Dr. Jonathan Gravel, and I'm one of your Base Hospital physicians. We hope you're all enjoying the new OMC model. I'll take this opportunity now to remind you to call us anytime. Today, we're going to be talking about buprenorphine naloxone in the pre-hospital setting. Given that that's such a mouthful, I will refer to it as Suboxone throughout this short video. So let's get right to it. Opioid disorder is very common. You know this better than I do. You as paramedics are on the front lines of this disease. You're deeply immersed in not only the withdrawals and the overdoses, but also its many downstream medical complications. There are a number of effective evidence-based treatments for this disease, collectively referred to as opioid agonist therapy, or OAT. Examples of OAT include Suboxone, the subject of our discussion today, as well as methadone. OAT has the potential to break the cycle of intoxication and withdrawal, it reduces cravings and the risk of overdose, it even blocks the effects of other opioids. Essentially, it works, and people who are maintained on OAT typically experience improved health and social functioning. So, what is Suboxone and how does it work? Suboxone is a partial agonist at the mu opioid receptor. This is the same receptor that fentanyl and other opioids bind to, but unlike fentanyl, it only partially activates these receptors and thus decreases opioid withdrawal symptoms without the euphoria and without the risk of respiratory depression. Who should get Suboxone in the pre-hospital setting? As seen in the ALS opioid toxicity and withdrawal medical directive, the indication is someone over 16 that has received naloxone for a current opioid toxicity episode who is now exhibiting opioid withdrawal defined as a COWS score of greater or equal to 8. What about dosing of Suboxone? The dosing's pretty easy. 16 mg sublingual to start and a possible second 8 mg dose at 10 minutes for ongoing symptoms of withdrawal. Are there any contraindications to Suboxone? The only contraindications are a known allergy, methadone in the last 72 hours, and though not a true contraindication, but always be extra careful to ensure that your patient is in adequate withdrawal as to avoid precipitated withdrawal. Despite OAT being a potential long-term treatment for opioid use disorder, it is important to remember that in the pre-hospital setting, and generally in the emergency department, it is symptom management. I think this nuance is important. It's a bit overwhelming to suggest to someone in Florida withdrawal that you're initiating them on a long-term medication. If successful, they may be more likely to appropriately engage with you, more likely to accept transfer to hospital today, and possibly more amenable in general to discussing their disease in the days to come. A few last summarizing thoughts. First, as this is new to many of you, a patch point is required in many regions, so don't forget to patch when considering Suboxone, or if you have any questions about it. Second, always think harm reduction, even if they say no to Suboxone. This can be as simple as reminding these patients to not use alone, to always consider a test dose, to always have a naloxone kit on hand, or going as far as to provide them with information for substance use care in your region. Third, everyone deserves kindness, respect, and compassion. Opioid disorder is like any other. Thank you all for your continued dedication to the advancement of paramedicine in Ontario, but most of all for providing patient-centered care every day. Cheers, and chat soon on the Patch.